If you're a woman that needs help and needs some wraparound services, we at the Delaware Health Equity Coalition, Dr. Sydney Teal, Dr. Velma Scantlebury, and myself, we'd be more than happy to see you. We are located right in 19802 on Boehner Boulevard. See you soon.
Welcome to a special episode of Every Woman, Her Health. I'm Dr. Velma Scantlebury, and tonight we're diving into a very important conversation about her health in honor of March being National Kidney Month. This is an opportunity to raise awareness about kidney disease. And I want you to know there are some very alarming statistics. There are over 35 million people with kidney disease here in the United States. That's 1 in 7 persons. And do you know that 90% of them are not even aware of the fact that they have this kidney disease? We do know that there are common causes of kidney disease that we're most often aware of, such as diabetes and high blood pressure. Do you know that for African Americans, we are nearly 4 times more likely to develop kidney disease and kidney failure than white Americans, and that women are actually more likely than men to suffer from chronic kidney disease? It's time to change the narrative. We need to empower ourselves with knowledge and take control of our health. Welcome back to Every Woman. I am Dr. Velma Scantlebury, the first Black female transplant surgeon in the United States, and I'm so honored to be here tonight to discuss this topic that affects so many women. Kidney health. All kidneys do more than we realize, and taking care of them is essential to our overall well-being. Before we begin, I would like to take a moment to thank our sponsors, the Delaware Health Equity Coalition and Delaware and the social services, Delaware Health and Social Services. Tonight, we have an incredible panel of experts and advocates who are going to share their knowledge and personal experiences. So let's get right into it. Ladies, we're going to introduce ourselves, and I'll start with you.
Wonderful. Good evening. I'm Michelle Miner.
Hi, I'm Helen Chang de Guzman. I'm a nephrologist, and I practice in Newark, Delaware, and in Elkton, Maryland. Thank you for having me on your show.
My name is Nancy Woodson, and I'm a 2-time kidney transplant recipient.
Hi, my name is Latasha Moore, and I am a 1-time transplant recipient.
Thank you so much. And so I want to ask the audience and viewers at home, does everyone know where their kidneys are? It's often amazing that when we talk to young people or kids, they're really not aware of where their kidneys are, and most importantly, we're not even aware of all the important things that our kidney does. So one of the things I would like to dive into with Dr. Chang is to talk about kidney disease. Most people, in hearing about kidney disease, they will say, well, how do I know I have kidney disease?
Okay, well, kidneys are essential organs. The main job of kidneys is to filter the blood and make waste products in the form of urine, to manage the body's chemistries, the electrolytes, and also to balance the fluid management in the body. Your kidneys actually sit back in the small of your back. Most of us are born with 2 kidneys, so they're about 10 to 12 centimeters each. And like what you had said, there's 35 million Americans that have kidney disease, but only 90% actually are unaware of that they have kidney disease. So you realize that often kidney disease has no symptoms at all, and patients come to doctors or family doctors with other medical conditions, and they find out that they have chronic kidney disease. So often there's no symptoms, no signs or symptoms. Now there are a small population of people where they have classically some hypertension, they might have some swelling, they may have proteinuria, which appears as foam in the urine, or hematuria, which means blood in the urine. But that's kind of the smaller subset of patients, and most patients actually don't know that they have chronic kidney disease unless they go to a healthcare provider and they look at their labs, and all of a sudden they see, oh, you have kidney disease.
That's incredible. And one thing I often see in my patients is they'll have some pain in their flank area, and they say, okay, something's wrong with my kidneys. Is that often true?
Most of the time when people have back pain, it's actually musculoskeletal, because kidneys don't typically hurt unless you're passing a stone.
Good to know, good to know. So I'm going to ask you, when you see young people in your office who are referred to you to have their kidneys checked, what is generally the driving symptom that gets them referred to you?
It's usually some other chronic illness that brings them to my attention. So they may have some underlying hypertension during a younger age, young adulthood, or they might have pre-existing diabetes. And so diabetes being the #1 cause of kidney failure in the US, we screen them because, again, kidney disease is silent, and so they may not know that they have early kidney disease unless we actually test them, blood and urine tests. So the key is really early identification of chronic kidney disease, whatever the cause. But the most common cause, diabetes, hypertension. But for younger people, you'll have to see if there's any other systemic symptoms, things like glomerular disease, autoimmune disease, particularly in women, things like lupus, maybe a little bit more prevalent in a younger female population.
Nancy, you tell me about your story. Tell us about your story initially and your original diagnosis in terms of what caused your kidneys to fail, and how old were you at that point?
Okay, I think I remember my senior year in high school. I missed the large majority of the second half of my senior year in high school thinking I had the flu. And like you said, people don't know that you have kidney failure until, aside from, another issue that brought you to your doctor. And I thought I had the flu. By the time I got to the hospital, because I had a fever that wouldn't go away, my kidneys were only working 15%. So
15%.
15%.
Wow.
Yeah.
And you were in high school?
High school, senior year in high school, and I wasn't sure I was going to graduate because that last half I didn't see school in and out of the hospital. But initially they thought it was lupus, and they tried to treat me for it, but it wasn't effective because later I found out that was not a proper diagnosis. So to date, I don't know why my kidneys failed. So, but like I said, I'm a 2-time kidney transplant recipient. My initial transplant was in '94. And it was like 10 years after my high school graduation. My sister Robin was a living donor for me, and it gave me 10 years to spend time with my son and my family. But after 10 years, I think I got a rejection from a cold or an infection or something that happened, and caused my kidney to fail. So I had to wait 4 years on dialysis from my second transplant in 2007. And she's still going strong. So this year will be 18 years in August. With my
Incredible.
second kidney transplant.
Wonderful, wonderful.
Gotta hold on to this as long as it will last.
Yes.
But
When you discovered that you have less than 20% of your kidney function, what was presented to you as far as the choices for treatment? What were your options at that point, now that your kidney function was so poor?
dialysis. And I had no education about what dialysis was. The way it was described to me, I was like, I gotta have something out of my neck and be attached to a machine. So, however, the initial dialysis experience that I had was really short. I took 4 months and my sister donated her kidney. My true experience with dialysis was in 2006 when my first kidney failed, and I had, 2004. I had to wait 4 years for another kidney transplant. And so 4 years on dialysis was treacherous. I didn't like it, but it was the only option I had, so.
Understandably. And Dr. Chang, explain to us the difference of the different types of dialysis, and do patients have any other choice other than going on dialysis when the kidney function gets to be less than 20%?
So when people have late-stage chronic kidney disease, you're typically seen by a nephrologist, and they educate you about your choices for dialysis. There's two main types of dialysis. One is called hemodialysis, and the other one's called peritoneal dialysis. About 90% of people on dialysis do in-center hemodialysis, which means that they go to a dialysis center. It's artificial kidney replacement. When your kidneys don't work, these dialysis keeps you alive. So about 80 or 90% of patients do in-center hemodialysis, where they go to a center, their blood is literally cleaned through a machine and gets returned back to you, typically about 4 hours, 3 times a week. There is a spin-off of hemodialysis called home hemodialysis, where the person can get trained to do it themselves, but they need to do it themselves, or they and a care partner does dialysis at home. Now, the other kind of dialysis is called peritoneal dialysis, where a tube gets surgically placed into the abdominal cavity. So this abdominal cavity is called your peritoneum. So the peritoneum has a kind of a sac where all of your organs, your vital organs, sit inside this sac, and a tube gets surgically placed, permanently placed into your abdominal cavity. This type of dialysis is different. This is a home modality where fluid gets inserted through this special tube. This is sterile, especially medical grade dialysis solution gets placed into your abdominal cavity. It dwells. It dwells and it absorbs through diffusion. The waste products, electrolytes, waste products, and extra fluids gets almost like a sponge, or almost like it gets drained through this. It dwells, it absorbs, and then you drain out the peritoneal dialysis fluid, and you have to do this is called an exchange, and you have to do several exchanges every night, typically on a cycler machine. So that's the other kind of home dialysis called peritoneal dialysis.
And at what point do patients have to think about dialysis or replacing their kidney with a source of treatment?
So typically when patients are followed by a kidney doctor and they see that their trajectory is going down, we start preparing a patient for dialysis and or getting simultaneously evaluated for kidney transplant if they are a candidate. So if you see that the trajectory is going down, we try to, this is obviously a very emotional, when somebody's going through organ failure, that you need to prepare and break it down for the patient and meet them where they're at, discuss so that you're well prepared as best as you can be, preparing for the time when your kidneys aren't working, whether or not you're able to preemptively go to a transplant or get waitlisted for deceased donor transplant, or prepare yourself for dialysis, whether it's hemo or peritoneal dialysis.
For all the parents that are out there, I mean, you were in high school, and you think about what could have been done to preempt, or to some tests that could have been done to anticipate that your kidneys were failing. Is there something that we can tell our audience that, if you have children, make sure that you're looking at A, B, C, and D, or asking your doctors to check A, B, and C?
So in terms of like pediatrics, pediatric patients, what's really important is having your children have a healthy lifestyle and eating well. If you notice that your child's not developing, so they're going to the pediatrician regularly or their family doctor regularly to see that their growth is appropriate. And we don't typically, for children, we don't typically draw blood work on them. But if you notice that, hey, there's something wrong with my child and their blood pressure, normally children do not have high blood pressure.
Right.
So that's kind of a red flag as soon as you see, oh, blood pressure's high. Often they are referred to a specialist, or their primary care provider starts to dig a little bit deeper, because most children are not hypertensive.
Yeah. Is there anything, what about the urine? Is there a test that we can say, check your urine?
So for children, infections are probably more common, so UTIs are more common. In children, particularly smaller children, they might have more of a congenital problem with their kidneys. but you're looking for blood or protein, or you look that your child's not developing right. Maybe they have swelling, maybe they have hypertension. Those are probably the key things that will alert parents to say, hey, I need to get my kid checked out. Mm-hmm. Or, unfortunately in Nancy's case, she had some overwhelming illness and presented already in late stage. Now we don't know, we can't fill in the blanks to say, well, what happened?
Yeah.
We don't happen. She already presented in a very late stage. Could it have been prevented? I'm not sure. If you had any other signs before.
I used to get a lot of ear infections, and I've had measles, mumps, chickenpox. I was always the sickly child. And it wasn't until I got sick and went to the hospital, I realized you weren't urinating as much as you probably should have. I didn't pay attention to that, High school, you just don't, not something to look for. Did I pee today, or did I have a bowel movement today, or kind of thing. But it wasn't until that point I couldn't get rid of a fever, wouldn't go away. It was like 102 for like 2 weeks, and I had one sharp pain, and my sister took me to the hospital, and that was it.
Did you ever have foamy urine, like really foamy?
I never paid attention to that. Now I do. Afterwards, all the time. But back then, I didn't check for that.
Yeah, which is quite unusual, because when we look at our African American population, we see that there's a higher instance of chronic kidney disease. And one of the things we didn't talk about was about the stages of chronic kidney disease. When, stage 1, when it's probably less than 80% or greater, I'm not sure, all the way down to, as it deteriorates, then you go through stage 4 to stage 5, and stage 5 is when you get to less than 20% and you need to think about replacement therapy. But what's different about African Americans presenting with chronic kidney disease at higher proportions than white Americans?
So African Americans they do have a higher incidence of chronic kidney disease. Part of it could be, part of it's genetics. So there is a mutation that's very common. It's called APOL1. It's a gene that all of us have, but in African people with African heritage, they have a higher incidence of this genetic mutation. Now you can have 1 or 2 copies. If you have 1 copy, your risk of having kidney disease is higher. If you have 2 copies, your course of chronic kidney disease is often accelerated. And that's why people with African heritage. Now this gene is actually, everybody has it. The mutation is actually teleologically in Africa, so it provides some immunity and protection against African sleeping sickness, right?
And malaria.
Trypanosomal brucei. I had to look this up last night. If you have 1 copy, so it's thought maybe somewhere between 30 and 50% of African Americans have 1 copy of this APOL1 variant, and about 15 to 30% have 2 copies, and the people who have 2 copies are really at high risk for malignant hypertension and progressive kidney disease, whatever. If they have any propensity if they have any touch of diabetic kidney disease, hypertensive kidney, lupus, whatever, HIV, nephropathy, it just accelerates the progression of kidney disease. And these are the younger patients that end up on dialysis, are in their 30s, because they have another pre-existing comorbidity, and this APOL1 just ravages their kidneys. It accelerates kidney failure.
And so often you see patients who have a family history. You go back and the parents have kidney disease, or somebody's on dialysis, and so they have multiple family members who have high blood pressure at an early age, leading to kidney disease because of the acceleration. And isn't it true also that for African Americans, as far as high blood pressure, they require many more medications, maybe 3 or 4 meds to control the high blood pressure compared to Caucasians?
Yeah, that's true.
Yeah, and so that can lead to chronic kidney disease. And so let's go to you, Latasha. How old were you when you were diagnosed with your kidney disease?
I think I was like 22. I'm gonna say I just had my son. My mom, and she rests in peace. She kept saying, Tasha, you have suds foam in your pee. And I'm like, what are you talking about? Because sometimes she would be in the bathroom, like if I'm getting dressed or she's getting dressed, so I got to go to the bathroom. She'd be like, you got suds? And I'm like, what are you talking about? So she sent me, I guess she must have talked to one of my cousins because he was on dialysis, and got set up with the doctor. We had the biopsy and all of that stuff. Yes, I had hypertension, all of that. They put me on medicine and all of that. Then they came back and say I have something called FSGS. This is really long name, focal.
Like Dr. Chang explained that to us.
Glomerulosis, something. FSGS.
Focal sclerosis glomerular.
Yeah, that right there. But I'm going to say it into the sense of layman's terms. It's basically your kidneys produce too much protein. That's probably where I was spilling it out in my pee. That was the foam in my urine. Fast forward, Dr. Chang is my doctor, my nephrologist. Yay. She prepared me. She said, Tasha, you're going to need a kidney. At that time, I was probably, so I was in like my early 20s, probably like 25, 26. I was like, we'll worry about it when we get there. I'm not worried about no kidney right now, because we're young. You're not thinking about it. You keep going with your life. I had a kid. Time moved forward. She's like, what are we going to do? I'm like, what do you mean? She's like, you got to think about dialysis. I was like, I got a kid that plays football, that plays basketball. I don't have time for dialysis. She was like, okay, Tasha, but it's going to come. I was like, okay, no problem. We'll cross that bridge. What'd I say? We'll cross that bridge when we get there.
Yeah.
That bridge came. That bridge came in 2000. What are we in? 25. I got my kidney transplant in 16. I went on dialysis in 2014. I'll never forget this day. She was like, you're not going to feel good. I promise you, you're not. I was like, she was like, you're going to go into uremic shock. And I'm thinking to myself, what is uremic shock? I'm like, I don't know what it is. Oh, I found out what it was. I couldn't lay down on my back. I think I had too much fluid on me.
And that's basically when you're full of all the waste products.
Of waist,
and your kidneys can't get them out, and so you need to be on dialysis.
I couldn't climb stairs. Like I was out of breath. Like, oh my God, I was not wanting to go to the hospital. I did it for 2 weeks. I was like, I can't do it no more. Yeah. I can't. I was trying to fight it to the end of my son. It was my son's senior year in high school. I'll never forget. I was like, I can't do it no more. I got to go to the hospital. My uncle took me to the hospital. She comes in the room. She rubs my hand and say, it's time, baby. I said, I'm ready. Let's go. I was on dialysis for 2 years. Thanks to her, she put me on the transplant. She made me go on the transplant list. In 2011, she was like, well, if you don't want to go on dialysis, go on the transplant list. So I said, okay, let's go. So I did all what I needed to do. Got on the transplant list. You get several calls, 1,001 calls. Then that day came. The day before, I was at Great Adventures, y'all. I lived my life like you wouldn't even know I was on dialysis. I promise you. But and they called me August 15, 16. I'll never forget that day. They called me and said, "This is your time. You number 3." I was number 3, but they called me later on, and she was like, "The first 2 ahead of you, they are sick."
And you said, hallelujah.
I said, hallelujah. He said, be at the hospital at 9 o'clock. And awesome. I was at the hospital and everything was in the history book.
So Dr. Chang, tell us about FSGS. What is this lung disease and how often do you see it and how does it present?
Focal segmental glomerular sclerosis is it's not a very common, but we do see there's 2 flavors of FSGS. One is idiopathic, where we don't know what causes it. It may have something to do with the APOL1, but it is a glomerular disease, meaning that it attacks the glomeruli, which are the filtering units. There are secondary forms of FSGS from medications, sleep apnea, obesity, other prior injuries, and when the kidney recovers, it will spill out protein, which is what your presenting symptom is, like that sea foam that you see in the toilet. You have to flush twice.
Yep.
It's not just bubbles. It looks like sea foam. You have to flush twice, and then that's protein in the urine.
And so when you talk about glomeruli, there's like little ball things in the kidneys.
The filtering
like
units.
Filtering the blood goes through and filters out cleanses the blood.
Right, and when there's a breakdown in the filtering units, things will come out in the urine, which is the protein. Your kidneys have, a million glomeruli in each kidney. The kidneys act as a filter. Each glomeruli acts like a filter. So it filters your blood, gets rid of waste products, electrolytes, but it's a pretty tight filter. And so when there's a breakdown in the filter, things will sieve out. And that larger particles like protein should not come out through the filter. And so when it does, there's a breakdown in the filter. That's why people will present with foam in the urine. And we do our dipstick, our poor man's test. We do a dipstick. We're not supposed to see much blood, and we're not supposed to see much protein in the urine. So if we detect those, that's a check engine light, and that typically sends you to the nephrologist or at least some other, investigation.
And is that also an important test, even for routinely, if someone, you see it, you don't normally see it with good kidney function.
Right, you shouldn't have much blood or protein at all. And so if somebody has a coexisting problem like diabetes, one of the hallmarks is that you have proteinuria. Often when you're seeing your doctor, if you have diabetes, that's the first thing that they're going to say. Here, give me a urine sample. I'm going to test you for the earliest and the traces signs of diabetes is protein in the urine, even before you can detect it in the blood.
Very interesting. That's something that we want our audience to realize, that a simple test, dip in a dipstick to check your protein in your urine. And we know that even with a transplant and a functioning transplant, we continually check your urine for protein because there are no particular signs and symptoms to say that there's something wrong with your kidney other than your numbers or just no symptoms. You don't know whether it's swelling in your legs, you don't get a headache, fatigue, those things are pretty much routine. So thank you all for sharing your story. And so we're going to get to Michelle, who's going to tell us about her journey with her mother who was diagnosed with kidney cancer.
Yes. First, I want to say I'm really honored to be here because I'm learning so much in this very moment that I think is going to be critically useful for the next leg of my mother's journey. And so in January 2024, I took my mother to the emergency room, and we took her there because she was having some general pain on her side, and she had a cold and just wasn't feeling well, so we took her into the emergency room. She lives in DC. She's been staying with us in Delaware. She's 72, and we're happy to have her with us. And so we took her to the hospital, and while we were there, they really couldn't find out what was going on with her and why she was sick, but they kind of haphazardly told us as we were getting ready to leave, we saw they took a scan to find out what was going on with her stomach, and they saw a small spot on her kidney. And that's what they said. Nothing we need to manage here. We just want you to go back to your primary care physician. Needless to say, it didn't seem like anything big to us, and probably took us about a month or so to get an appointment, and then a month to get on the books, because for some reason, it's just really hard to get a quick appointment with your doctor, even when you say something like, they saw a spot on my kidney. So we finally were able to get in with her primary care physician, who referred us to a urologist. And the urologist called us in for a scan. And when we got the scan, we had a call, and the doctor shared with my mother that the spot, she had a 3.5 centimeter, what he called at that time,
kidney mass.
Mass, yes, small mass on the kidney. And he was very, he seemed very calm about it, and I guess just didn't want to alarm my mom. At no time at that point did they call it cancer. just said it was a mass and that it was 3.5%. And they said, you know, we could wait. We don't have to do anything right now. And I remember my mom's face, like, what does this mean? And I could tell that she was very scared in that moment. And I remember saying to that doctor, we need to move. I said, even if it's not for her physically, is what I'm hearing you say, for her emotionally and mentally, we need to have a plan to address this, and we need to understand better what this is. And so from there, we came in and they had to do another CT scan with contrast dye so they really could understand what was going on. And then they finally said that this was kidney cancer. They initially shared with her that they could do a cryoablation to kind of go in and freeze that area. And through a series of appointments, we actually never got the cryoablation done. And a couple of things happened. My mom was sick on one of the appointments to have the surgery done. Another time, the doctor had to reschedule. And by the final time when we went in, she got on the table, she went back, they completed the biopsy, and what they saw was that we were initially told that the tumor had been there, probably had been there for a really long time, and was slow growing, and there was nothing to worry about. By the time she got on the table and they did the biopsy, they realized that it had grown from 3.5 to 5, and they could not complete the cryoablation. And they then informed us that it's growing faster than we thought. And so, you know, we were pretty upset. We were like, why didn't we get it done sooner? Why didn't we get that cryoablation done? We could have had this over with. And I remember just recently before her surgery, asking her doctor, I said, you know, we're usually on it. Things happen pretty fast for us. We make things happen. I said, I just didn't understand why this cryoablation didn't happen. We could attack this early. And the only thing that I received, you know, and I prayed about it actually, was that that wasn't what we needed and they might not have gotten it all. And when I shared that with her doctor, he said, in fact, you're probably right. We didn't know that it was growing as fast as it was. And actually removing the kidney is our best course of action now. And I was so grateful in that moment because, of course, you're upset. You think you missed an opportunity. And then when we realized that we really needed to get the kidney out, and that was the best course of action, that's the direction we went. And we went really fast. We made the decision to move really quickly. And on just this past Thursday, a week ago today, my mother had her right kidney removed due to that cancer. And she's at home and she's recovering well. And we're really, really grateful for that. And they said she has a 99% chance now of that not reoccurring. And before, the numbers were a lot lower in terms of having that cryoablation. So we're really grateful that we took the course of action that we did and that the timing all aligned in the way that it did.
Well, thank you so much for sharing your story. And Dr. Chang, does everyone have 2 kidneys?
No. Most people do, unless they have, you know, if they're born with some congenital abnormality. But most times we don't know until another problem brings it to fruition where, oh, I have abdominal pain, you go to the ER and they scan you or they do an ultrasound. Oh, you only have 1 kidney. So it's not something that you would know unless we went looking for it or looking for something else.
Should her mom be concerned about having 1 kidney?
Well, I'm glad that the tumor is out, but remember that God blessed us with 10 times the amount of kidney function that you need to survive. You only need 10%. We're born with 100, assuming you were born with 2 kidneys and not have, you know, you weren't born premature or you weren't, you know, have a congenital abnormality. So we're born with 10 times what we need. As long as we stay north of 10%, you don't need dialysis. So yes, we can actually donate a kidney and still be okay with 50% mass, even though you lose 50% of your mass. And so there's where we can say, well, living kidney donation, we can segue into living donation is a good thing. And so people who are healthy, they are able to donate, or in your mom's case, she by default, she had to remove this kidney by default, but she could still live with the other kidney. Now that you know that you have less reserve, and this is what we all tell our living donors, you have less function now because you only have 1, you better protect what you have.
That's right.
Which means you need to Make sure all of your risk factors are well taken care of. Things like hypertension, diabetes, sleep apnea, obesity. If you're a smoker, you better stop because you're going to smoke the rest of that kidney away. And so those are risk factors that are remediable, and we can address it to reduce her risk for decline. By definition, yes, your mom has chronic kidney disease, not just from age, as all of our kidney function does deteriorate over time with age. But then she lost suddenly, because of the tumor. She had to remove 50% of whatever she had. So whatever she's got to take care of, and as well as everything else that all her other comorbidities need to be addressed aggressively. And actually, there are medications now that can help. Now, I can't grow her a new kidney, not yet. We don't have that technology to clone anything, but there are medications that can be added to reduce or slow down progression of kidney disease. And so that's why she should see a nephrologist or a family doctor to make sure, not just that the tumor doesn't recur in the other kidney because she's got one, but that she protects the rest. She does everything possible to modify her risk factors, and there are certain medications that can be given to help preserve whatever's left of the remaining kidney.
So good to know.
So as long as she stays north of 10%, that's what, we're looking at the trajectory.
And that's why it's so important that we get educated, that we have that knowledge and understanding, so that even if our doctor doesn't bring it up, you want to know, what's her residual function? What can you do to protect it? What can you avoid to make sure that you're not causing more harm to what residual function that's left there? And so thank you so much for sharing your story. So one of the things I wanted to touch on before is to think about what other, we know that there are patients who have polycystic kidney disease, and that can result in kidney failure. Tell us a little bit about some other conditions other than polycystic kidney disease that as women we should be aware of or think about checking to make sure. Like for instance, your mom was diagnosed because of another complaint, and they discovered this mass on a CT scan. And isn't it true now that we find a lot more incidental cancers because people are getting CT scans for various reasons? What are your thoughts on that?
CT scans are necessary to a nice window to your, to diagnose what's inside of you. Are you asking like having too many CT scans?
No, just the thought that, like for instance, we evaluate patients for, say, even for a lot of patients come to me and they're concerned about cysts on their kidneys. Not every cyst is necessarily something to worry about, but oftentimes they're diagnosed because they have a test done, either an ultrasound or a CT scan. When do you raise the alarm, or when do you think these people should get more concerned about things that are found on their CT scans?
So if there's other lab work that's abnormal that would go along, or family history of, say, polycystic kidney disease, that they have multiple cysts on the kidneys. So it's not uncommon to find a couple cysts or as solitary as we age. It's not uncommon to find a cyst or two on your kidney. You've seen that in the operating room when we have donors.
So for regular cysts, you shouldn't really, it's not much to worry about.
Regular cysts, we
a
don't
large
need to worry.
percentage of people have kidney
right.
cysts, right?
But if it goes along with the family history or progressive kidney disease, progressive decline, so polycystic is a very classic looking, the kidney is very large and distorted. So you've removed polycystic
Right, it's almost like
kidneys.
having a bunch of grapes all over your kidneys, small size, big size. And so most of that is often for polycystic kidney disease. Isn't it mostly genetic?
That's right, the autosomal dominant polycystic kidney disease is number one genetic kidney disease leading to failure, typically in the 5th decade of life. Typically, there's also associations with other cysts and other deformities like aneurysms, mitral valve, cysts on the breast, cysts on the ovaries. But that's the most common, but in the scheme of number of patients on dialysis, it actually represents maybe 5, maybe 10% of the total population on dialysis.
Yeah, we do see some patients with, other than your diabetes, hypertension, your FSGS, and unknown,
Right.
and unknown factors, the unknown factors, things like, how often do you see like chronic urinary tract infections? Can that result in kidney disease?
If you have frequent, more so not UTIs, but more pyelonephritis, where you have repetitive, sometimes it's with stones. And over time, if somebody has frequent pyelonephritis, they'll develop chronic kidney disease, but not necessarily lead to end-stage kidney disease.
So that's when the infection leaves the bladder and goes up to the kidneys. So so that would then lead to infection in the kidneys itself.
And then damage to the parenchyma. Or it can come from intrinsic, but most of the time it's UTIs that may have been left untreated.
Right, and so with kidney stones, which are often a nidus for infection or may block the kidney. So those are things, if you're having issues with your kidney, make sure you talk to your doctor about it. If you have a family history of kidney disease, you want to make sure you get checked. And we talked about options for when you start to deteriorate as far as your kidney disease, you get to stage 5. The options are either transplant or dialysis, right?
Primarily, right.
Are there other options?
Should I say, if somebody's quite older or frail and dialysis is not a great option, people can consider hospice and not doing dialysis at all and just live out whatever's their life. Whatever's left of their life.
My dad was diagnosed with kidney disease when he was 89, and he opted not to go on dialysis because he had to take care of my mom. And he stayed off of dialysis until he didn't deteriorate until he got to 95.
95,
wow.
So, yeah.
Wow.
So, yeah, so he got to...
Chronic medical, just medical management of kidney disease without dialysis. Yeah, dialysis is not fun. You were on dialysis, and it's not fun, but you got to do what you got to do to survive.
That was my option.
To survive, right?
So we want to, what are your take-home messages from this conversation today? What would you say you would want to let people, the audience, know about your disease and your journey, even though dialysis was hard?
Pay attention. Just pay attention to your body.
Yeah.
Your body is your temple. If you see something ain't right, call the doctor or talk to someone. Even you youngins out there, like if you feel like something's not right, talk to somebody, because by you not talking to somebody, you're just making it worse for yourself, down the line.
Absolutely.
Me personally, I was a tough, listening to somebody. Like I was in my early 20s. I didn't want to hear that. I had hypertension. I have hypertension, but I didn't want to take my medicine. I didn't want to do what I was supposed to do. And here we are. You get down the road and then you have to go on dialysis and get a kidney transplant. I definitely thank the man above for giving me a second chance at life. But
Awesome.
I just, if I had to do it all over again, I would
do better.
I'll probably do better.
Right? You'll do better.
I definitely would
Absolutely.
do better. But pay attention to your body.
Absolutely.
Yeah,
And
pay
Nancy, you
attention to
have
your body.
grandkids, right?
I have 6 grandkids.
You have 6 grandkids,
Yes.
so you have had an incredible journey
I have.
and get to this point. So.
I have, yeah. My son was younger. He was in 1st grade when I started dialysis. So thank God I was able to see him graduate high school,
Yes.
college. And when I was a grandmother at 50, I was like, I'm too young. But then I was like, when do I think I was going to become a grandmother? So I'm pushing 60 now.
You look amazing.
Awesome, awesome.
Yeah.
And what would you say, Dr. Chang, in terms of telling our audience things that would, knowing that kidney disease is really without any major symptoms?
Yeah. So kind of the three take-home points is that what I advise all of my patients, eat healthy, exercise, try to maintain a healthy weight. 2, don't smoke.
Yeah.
Don't smoke, please don't smoke. And the third point is, if you have diabetes, okay. If you have hypertension, okay, treat it. Treat it aggressively, whatever your other comorbidities may be. Heart failure, could be sleep apnea, whatever your other comorbidity, treat it because it can secondarily accelerate chronic kidney disease. And then 4, see your doctor, because this is a really exciting time. We have medications that, there's lots of medications coming out in the woodwork, in the horizon, not just medications that can slow down and hopefully, right now we have medications that can slow down chronic kidney disease progression. So it's really important to try to slow down everything. Right now, I can't grow you a kidney. Maybe someday we will have medications that can actually reverse the damage. Right now we have medication, just generic blood pressure medicine. We have medications that will slow down progression, but someday we're going to have medication that may help regenerate and correct or reverse prior scar tissue. So make sure you're seeing your doctor. There's a lot of medications in the horizon.
Well, thank you so much. And Michelle?
Yeah, a couple of takeaways for me. The comorbidities that Dr. Chang just mentioned, my mom has all of those. And those are prevalent in my family. I have 2 beautiful daughters. And I think about them and how we live in our lifestyle and what you noted about living a healthy lifestyle, eating healthy, exercising. Those things are really critical for my husband and I now, but also because of what my mom is experiencing, it's critical for us to push her. And so I know that we have to support and guide her in that space. And I think the second thing is education. Don't wait to educate yourself in a certain area. No, get the information. If it is anywhere in your sphere, do the knowledge is what I say.
Yeah.
Get the research, find
Know your
out.
family history.
Know your family history. Go to seminars, get educated. The information is out there so that you learn, and that I think ties in with knowing your body and being able to follow through as you need to. Yeah.
Well, thank you all so much. We've had an incredible conversation tonight about kidney health, which is something we cannot really afford to overlook. And I hope that this discussion has empowered all of us to take charge of our well-being and living healthy lifestyles. And remember, early detection is important. Lifestyle changes and awareness can make all the difference in preventing kidney disease and improving our overall health. A huge thank you to our amazing panelists for coming out and sharing their expertise and knowledge and their stories. And to all of you tuning in, please shout out to our sponsors, the Delaware Health Equity Coalition, of who many of these are my patients, and Delaware Health and Social Services. Let's continue our conversation beyond tonight. Talk to your doctors, get screened, get your urine checked for protein, and spread the word, because when it comes to our health, knowledge is power. Yes. So be sure to stay tuned and connect with Every Woman for more impactful discussions. And until next time, take care and take care of each other.